Hello ladies and gentlemen, and welcome to the Critical Care Nurse. Today we're going to be going over Pressors and Pressor-like medications, specifically adrenergic agonists and medications that have similar adrenergic agonist effects but work by different mechanisms and processes. So, let's get started.
Alright, so now we are going to break what the adrenergic agonists are. I'm going over what it is, different types, the receptors, and what medications fall into each of the classes. So first off, adrenergic agonists are medication um, that stimulates, and I'm just going to abbreviate it with the AA for adrenergic agonist receptors. So now the first class, two classes. The first class is the catecholamine adrenergic agonists, and we also have the non-catecholamine. Now each of the different ones have certain properties that go with each. First, for the catecholamine, the catecholamine adrenergic agonist is that it does not cross the blood-brain barrier, and the non-catecholamine crosses the blood-brain barrier. Catecholamine adrenergic agonists are short-acting. Non-catecholamine adrenergic agonists are long-acting. The catecholamines, they're IV and IV only, whereas the non-catecholamines, they are IV and also PO, because they do cross the blood-brain barrier. Now we're going to go over the different medications that fall under each group. So under catecholamines, the first was epinephrine. The second, norepinephrine. The third we have here is isoprostol. The fourth in this group, dopamine. And the fifth in this group is dobutamine. Now for the non-catecholamines, we have ephedrine. Second one in that group is terbutaline. And the third in this group is phenylephrine. So we're going to start out by going over the different adrenergic agonist receptors. I think this will be easier to start out by explaining what each of the receptors are, and then we'll go over above which medications affect which receptor. So in terms of the receptors, we have alpha 1, alpha 2, got beta 1, beta 2, and then we also have dopamine. It's the name of medication and one of the receptors. So we're just going to break it down by what happens when each receptor is agonized. For alpha 1, we will have vasoconstriction in the peripheral vasculature, causing an increase in blood pressure, and its corollary increase in the MAP, or the mean arterial pressure, which is super important in terms of the cardiac division. Now, alpha 2 receptors, they do a lot of different things, but for the most part, when it comes into ICU nursing, you'll have to understand that there's like a negative feedback. So it decreases the effectiveness of adrenergic agonists in the peripheral vasculature, thus decreasing blood pressure. Now, in terms of beta 1 agonization, we have a positive inotropic and positive chronotropic effect, which will, in terms of chronotropic, will increase cardiac output and the cardiac index, and will also, with the chronotropic, increase the heart rate. Now, for the beta 2 receptors, we have bronchodilation, which will give us increase in lung perfusion. Now, for the dopamine receptors, when they're agonized, we have renal vasodilation, and that vasodilation will cause an increase in renal perfusion. So yeah, so once again, alpha 1 will cause a vasoconstriction in the peripheral vasculature. Alpha 2, negative feedback, so it decreases the effectiveness of AA receptors in the periphery. Beta 1, positive inotropic and positive chronotropic effects. Beta 2 is bronchodilation. And dopamine will increase renal vasodilation and increase renal perfusion. So now we're going to break down which receptors are agonized by each of the medications above. So, don't mind the grandfather clock. So we have the epinephrine, which will affect the alpha 1, alpha 2, beta 1, and beta 2. Norepinephrine will affect alpha 1, alpha 2, and then beta 1 as well. Isoproterenol will work on beta 1 and beta 2 receptors. Dopamine will be alpha 1, beta 1, and of course dopamine receptors. And then dobutamine will have beta 1 and then mild beta 2 agonization. Now for ephedrine, we have alpha 1, alpha 2, beta 1, beta 2. Terbutaline will be beta 2. Phenylephrine will be alpha 1. So now to go over everything, epinephrine will have alpha 1, alpha 2, beta 1, and beta 2, with an emphasis on the beta 1 agonization, causing the positive inotropic and chronotropic effects. Norepinephrine will have an emphasis on alpha 1 agonization, causing vasoconstriction in the peripheral vasculature, thus increasing the blood pressure and the MAP. Isoproterenol, beta 1, so positive inotropic and positive chronotropic effects. Dopamine will be specific for the dopamine receptor, causing renal vasodilation and increased renal perfusion. But it also has alpha 1 and beta 1 effects that affect it pretty strongly. And for dobutamine, we have beta 1 agonization, once again causing positive inotropic and positive chronotropic effects. So mild beta 2, which will also cause, um, potentially cause a decrease in MAPs. So for ephedrine, which is PO, uh, turbulene PO as well, but phenylephrine has the alpha 1 agonization. And when levo is getting up to really high levels, then we usually add phenylephrine as well to help give us the ideal, or not the ideal, but the map that we want for the patient, whatever the map goal is. Now, in terms of, well, these are once again, the catecholamine adrenergic agonists and the non-catecholamine adrenergic agonists. Phenylephrine is also known as NEO. Norepinephrine is also known as levo. Isoproterenol, also known as isopro. So yeah, now so those are the other names for the medications. And then here are the receptors again: alpha 1, alpha 2, beta 1, beta 2, and dopamine as well. So once again, the catecholamines, epinephrine, norepinephrine, isoproterenol, dopamine, and dobutamine. And for non-catecholamines, ephedrine, terbutaline, and phenylephrine.
Alright guys, so I know we went over a lot, but there's a few things that I still want to go over because some of these medications do have very special considerations that you have to take into account. The medication I want to talk about is dobutamine. So with dobutamine, once again, we'll have the beta 1 agonization and the mild beta 2 agonization. So we'll have the positive inotropic and positive chronotropic effects. But then we also have vasodilatory effects when dobutamine is started because it is an inodilator. So it will vasodilate the peripheral vasculature, thus decreasing the afterload and making it easier for the heart to pump blood out. And that's kind of what we're wanting to do. When this happens, well, we can one of two things happens when dobutamine starts. It's either we start it and the blood pressure goes up because the positive inotropic and positive chronotropic effect supersedes the vasodilatory effects, in which case the patient's pressure goes even higher, while also giving the inotropic support that the patient needs. But then there's also the other side of it, being an inodilator, that the MAPS will tank while we're also giving the positive inotropy that the patient needs. In which case, it's always a good idea to have levo or neo on board when that happens. And with dobutamine, we usually will start when a patient has heart failure or cardiogenic shock. But it's very important to know all these receptors and how all these medications work in concert. Just because there's a while back where, because I work in a cardiac and transplant ICU, and I was getting a CCO overflow from the ED. So now the patient, when they came up, they still had a pressure like 90s over 60s, so which is adequate for us. But then quickly went down to like 50s over 20s, to the point where like we're basically pharmacologically coding this patient, but we didn't have the medications yet. So at that point, like we need to either fluid resuscitate the patient and also get our drip started. One of the residents said that let's start dobutamine. To which I was not completely thrilled at the idea, just because we're talking about the butamine. But in my experience, when a patient is already hemodynamically unstable and hemodynamically compromised, when we start the dobutamine, yes, we will have the positive inotropic effects with beta 1 agonization, but the vasodilatory effects will be so profound that the MAPs are going to tank even further. And at that point, the MAPs are already like 30s, 40s, so I wasn't completely thrilled. So what I really said to them was, I know that's what we're supposed to do with cardiogenic shock, because that's what we think the patient's in, but I don't think that the positive inotropic and chronotropic effects of the beta 1 agonization is going to supersede the vasodilatory effects of dobutamine, because it is a vasodilator, in which case the patient's pressures are going to tank and we're going to be doing compressions. So I suggested we start epi and levo, and they kind of looked at me like deer in headlights. And they said, like the textbook, with it being CCU and the difference between, medicine ICUs and then surgical ICUs, they said, no, we should probably still start it because the patient's in cardiogenic shock, in which case I was just like, well, we only have levo and epi, so I'm going to start these. Which was true, but, and, the dobutamine actually does come from pharmacy, but that was like one of those times where I was like, through experience, I knew that might not have been, that was a textbook answer, but might not have been the greatest for the patient, just because of the cardiovascular, the subsequent cardiovascular collapse, the potential for that if we had started. So it's really important to know all these medications, how they work in concert. Another medication, dopamine. So with the dopamine, once again, we'll have alpha-1, beta-1 dopaminergic receptor agonization. So alpha-1, vasoconstriction, beta-1, positive inotropic and positive chronotropic effects, and then also the dopamine causing, the increased vasodilation and the increased renal perfusion. Now with dopamine, we also have to be very careful, just because, it's a good medication for, if a patient pressures are low, and then we also have low urine output. Dopamine can sometimes help with the renal vasodilation to help get perfusion to the kidneys. But then it's also very arrhythmogenic in nature. Yeah, this is very arrhythmogenic in nature. So let's say, a patient went into AFib in the 50s, say 150s, and, you tell the doctors, you get the blood pressure, the maps are kind of like in the 50s, like maybe 50s, high 40s, okay, it's low. And, you order your amio bolus and you order your amio and you're still waiting for it to come. But, the doc says, hey, let's start levo. Which is a good medication to start, especially, the patient's MAPs are low. But we should also think that, with the levo, we're going to be agonizing alpha-1, alpha-2, and beta-1. And with the increase of the beta-1 agonization, we can actually further exacerbate the rate at which AFib. So now if it's at 150s, we might start the levo, it could be in like 170s, 180s, in which case, if that ever does happen where a patient goes into AFib and the MAPs are low and, they're really sensitive to levo, neo or phenylephrine is a very good alternative to maintain, since it only does alpha-1 agonization, it's going to do nothing with the heart rate, so we can maintain the blood pressure in the MAP while not further agonizing and exacerbating the beta-1 agonization, causing the heart rate to go up and causing like a worsening of the MAP. So those are just a few of the things to think about in terms of the catecholamine adrenergic agonists and which medications are better for what situations. But that's like a whole other video.
So now we're going to be going over pressure-like medications. There are really two that I just want to go over that we really see a lot in the ICU setting. The first one is vasopressin, also known as antidiuretic hormone. Once again, antidiuretic hormone is comes from the posterior pituitary gland, along with like oxytocin, and then there's the anterior pituitary that does all the different like FSH, LH, ACTH, a lot of end growth hormone as well. But in any case, vasopressin, also antidiuretic hormone, prevents the excretion of water Thus, it increases the amount of fluid in the vascular space and also increases the blood pressure. Um, so with vasopressin, this is a medication that we usually give for patients who are in septic shock, and also if we already have a bunch of adrenergic agonists on board, and the patient still needs a little extra support. Vasopressin is a medication that acts like a pressor, but does not have any effects on the adrenergic agonist. So it's something that we usually add on top of the other medications that we usually do. The second medication that I wanted to talk about is milrinone, also known as Primacor. Now, milrinone is a phosphodiesterase 3 inhibitor, which it prevents the breakdown of cyclic adenosine monophosphate. Abbreviated lowercase c, capital AMP, that is CMP. And because of this, we will have an increase in cyclic AMP levels. Because of this, we also have an increase in protein kinase A, also known as pKa. Now, when we have the pKa, it phosphorylates calcium and potassium channels. Thus causing an influx of electrolytes, which then increases contractility, thus giving us a positive inotropic effect. Now, milrinone also vasodilates the peripheral vasculature, decreasing the BP, also decreasing afterload. So milrinone, very much like dobutamine, is an inodilator that functions independently of beta 1 receptors and any of the adrenergic agonists. So once again, vasopressin and melatonin, antidiuretic hormone, and Primacor.
Thank you for watching. I hope I was able to help in some way, shape, or form, and if I did, please subscribe. Once again, thank you for watching The Critical Care Nurse. Let's save some lives.